Yeah, Dr. Rasmita, over to you, please.
Yes. So, hello, good evening, everyone. I am Dr. Shweta Surve. I'm the Regional Medical Advisor for the Hemato-Oncology team at AstraZeneca in India. And on behalf of AstraZeneca, I welcome all the MHG members, the speakers and the panelists, as well as the audience for today's session. We also have a special guest who's an international speaker from Canada, Dr. Sarit Asaleen. Welcome, ma'am. And today's topic would be on chronic lymphocytic leukemia. So this will be a 2-hour scientific discussion purely on the diagnosis and management aspects of relapsed refractory CLL. And without further ado, I would like to welcome Dr. M.V. Agarwal, the Chair-President of Mumbai Hematology Group, to open the session and introduce the chairperson as well as the speakers for today. Over to you, sir.
Thank you, Dr. Shweta. I'll just share my screen. Can you see my screen?
Yes, sir.
Right?
Yes, sir.
Okay, so good evening to everybody and good morning to Dr. Sarit Asaleen.
Hey, thank you.
Today's topic is chronic lymphocytic leukemia. This webinar is brought to you by Mumbai Hematology Group. It is supported by AstraZeneca and managed by Mice Ideas. I am grateful to Mr. Manoj Rawat, Mr. Parag Mahajan and the team AstraZeneca, Mr. Rajesh Sharma, Mr. Kalpesh and the team from Mice Ideas, the Executive Committee of Mumbai Hematology Group, Dr. Sarit Asaleen, our international guest speaker from Canada, national faculty, each one of whom is an eminent hematologist, a medical oncologist, and all you participants for sparing your evening. Please remember to ask questions, put them in the question box, and the faculty will be most pleased to answer them. Coming to our guest speaker for the day, Dr. Sarit Asaleen. She is a hematologist at the Jewish General Hospital, Montreal, Quebec. She is Associate Professor, Department of Medicine at McGill University, Montreal. She has a Master's in Clinical Epidemiology, and she completed a fellowship in drug development at the Cancer Trials Group. Since then, she has devoted her research time in conducting early phase clinical trials for the treatment of hard-to-treat leukemia and lymphomas. Also, she is the Associate Director of the Clinical Research Unit at the Segal Cancer Center of the Jewish General Hospital, where she has conducted over 100 clinical trials for the treatment of leukemia and lymphomas. She has led or participated in several studies of new treatments for CLL with BTK inhibitors, PI3K, SYK, and BCL2 inhibitors, as well as the novel anti-CD20 antibodies. She holds a Clinician Scientist Award from the province of Quebec and is the co-chair of the Hematology Disease Site Group at the Canadian Cancer Trials Group. A little later on, she will be speaking to us, and her subject of talk is optimal selection of second generation BTKIs for treating relapsed refractory chronic lymphocytic leukemia. Well, thank you for this, and now it's my pleasure to invite the chairperson for the first talk, and that is Dr. Krishna Ratnam Kannan from Chennai. He's consultant hematologist at Sri Ramachandra Medical Center and Sundaram Medical Foundation, Chennai. He's consultant bone marrow transplant physician at Cancer Institute, Chennai. The speaker in this session is Dr. Biswajit D. Dr. Biswajit D is additional professor and HOD, Department of Medical Oncology, Regional Cancer Center, Jipmer, Puducherry. And his lecture will be on management of relapsed refractory chronic lymphocytic leukemia in the Indian context, the current perspectives. So over to Dr. Kannan, please.
Thank you, sir, for your kind opportunity. I invite Dr. Biswajit, who has been my colleague at the Cancer Institute nearly a decade back, and now he heads the Department of Medical Oncology at Jipmer. And the topic chosen is very apt because we have a lot of options, but in the Indian context, because of the financial constraints, it might be difficult to choose whatever has been published, be it ibrutinib, even though its generics is available, venetoclax or obinutuzumab. And it's going to be a challenge for Biswajit to speak to us today regarding the management of relapsed refractory CLL in the Indian context because of the cost constraints. And all of us know that the management of relapsed refractory CLL depends upon various factors, the biological factors of the disease, whether it's got 17p deletion or IGHP mutated or unmutated, the disease-free survival from the last treatment, the age of the patient, comorbidity, and the last but not the least is the affordability of the patient. I'm sure Biswajit is going to touch upon all these factors. And of course, we can't forget, our allogeneic bone marrow transplantation in select cases, which could be an excellent salvage for a relapsed refractory CLL. So I look forward to hearing from Biswajit. Over to you, Biswajit.
Good evening. Thank you, Dr. Krishna Ratnam, and I would like to thank Dr. M.B. Agarwal and AstraZeneca for giving this opportunity. The disclaimer is that the slides have been provided by AstraZeneca and it's not my slides. So to start the presentation, the incidence and prevalence of CLL, we know CLL is the most common leukemia in the Western countries, but for some reason, the CLL incidence is quite low in India. So the age-adjusted incidence of CLL in Europe is 3.79 per 100,000, and while in India it is only 0.41 per 100,000. It's approximately 10 times lower than in US. If we go to the staging system, the two most common staging systems which have been used, one is the Binet staging system and the RISE staging system. And in India, we most commonly use the RISE staging system, which has 4 groups. I think everyone knows the different groups. This is important because it helps in deciding our treatment management. The next important thing is scoring. There have been 2 different scoring systems which have recently been used. One is the German CLL scoring system, and the other one is the CIPI or CLL IPI scoring. The CLL IPI is the one which we commonly use, and it has parameters like age, clinical stage, serum beta-2 microglobulin, the immunoglobulin heavy chain mutational status, and the TP53 status. This score does not only help in actually deciding what management can be done, but it also helps in this, gives us an idea of what will be the prognosis of this patient. So a patient who has a very high risk has a 0% chance that he will have a 10-year survival. Recently, this is generally this is very useful for high risk, intermediate, and high risk group. But in the low risk group, whether there are some patients which we could wait and watch and some which we could treat. So there is a new IPI which has come up recently published, which is the IPI yearly. So it's called IPI-E. So they have taken into consideration some factors and they divide them into a low risk, intermediate risk, and a high risk. And if patients on high risk, there is a 14% chance of getting the treatment done in the next 1 year. So this subset of patients can be considered for treatment. So this is a very recent publication, and maybe we could look at which patients in the early group can be treated. Coming to the treatment in the relapsed refractory, we know that CLL is 2 diseases. One is one with the deletion 17p, one without the deletion 17p, because the treatment management is completely different if you have a deletion 17p and if you do not have a deletion 17p. And options, when you do not have deletion 17p, you have little more options in terms of chemoimmunotherapy. And the most common treatment regimes which we use is, in the first line is bendamustine rituximab. So in a relapse setting, you either use chlorambucil rituximab or use a single agent rituximab, fludarabine based therapy is available. And then you have targeted therapies like BTK inhibitors, as well as you have venetoclax. So these are some of the therapeutic armamentarium which we have in patients with relapsed refractory CLL. When it comes down to somebody who has a 17p deletion, then obviously the chemoimmunotherapy arm is out, and then you just have the targeted treatments which are available. So coming on to the epidemiological estimates of CLL in the country, again, as we discussed, it's not as high as in US. The incidence is somewhere around 0.14 per 100,000, and the prevalence is around 10,000 with deaths around 1,641. So it has quite a low prevalence of CLL. One of the reasons being that probably our age population is not very high. Our pyramid is not aged, and patients are present in a younger age, have an aggressive course and a shorter time to treatment. The various drugs which have been approved for CLL, the first most common drug which in 1960 got approved was chlorambucil. For a long time, till 1990, there were no other new drugs approved. In 1990, we had this fludarabine combinations which got approved. And then in 2000, and then the chemoimmunotherapy with rituximab was approved around 2000. And in 2014, the targeted therapies got approved. And the current targeted therapy which is available in the country is only ibrutinib. The paper, there's one published, there's a paper from All India Institute of Medical Sciences, which had around 120 patients. They looked at bendamustine and rituximab in CLL patients. And as you can see, the overall response rates with bendamustine and rituximab was quite good with 90%, with complete responses seen in 45%. The median EFS was quite low in an unselected population, was 2 years, and with a median follow-up of 29 months. And the only thing which they found significant was the IGHV mutation status. Patients who had an IGHV mutation had a longer EFS of 27 months versus 18 months. The other drug which we have not discussed is one other drug which we could generally use is lenalidomide in a relapsed refractory setting. Recent meta-analysis shows that we could use lenalidomide, which has an overall response rates of around 50 to 60%. Now, the drugs which has revolutionized the treatment in CLL over the last few years has been the BTK inhibitors. And we know, so what we need to know about the BTKs are that they are found on the X chromosome. The BTK is a non-receptor protein tyrosine kinase. And there are two drugs. One is ibrutinib. The other one is the acalabrutinib. The ibrutinib is a non-specific inhibitor, and it inhibits multiple other kinases apart from the BTK, whereas the acalabrutinib only inhibits the BTK at a specific inhibition, which is the C481 binding region. Now, the drug ibrutinib got its approval from the Resonate trial, where they used ibrutinib at 420 milligram once a day and compared with ofatumumab. And it's very clear that the ibrutinib did very well with a median PFS of 44 months versus ofatumumab, which was only 8 months in a relapsed refractory setting. And you could see that the overall response rates also were quite higher. With respect to safety, the ibrutinib has side effects. One of the commonest side effects are diarrhea, fatigue, cough, and neutropenia and thrombocytopenia. And one of the other side effects which we see is a lymphocytosis, which has been described and which confuses us during the initial periods when we are not sure whether it's a progression or not a progression. So the other concerning side effect, which we generally tend to forget or which we should not forget, is atrial fibrillation, which is seen in 12% of the patients. And this needs to be kept in mind when we are giving ibrutinib. So obviously, there was one more study where we commonly use bendamustine rituximab in the country, and if you add on ibrutinib, whether we could get a better PFS. So this Helios trial definitely showed that the PFS was better when you added ibrutinib but the overall survival was very minimally, there was a minimal benefit from the addition of ibrutinib. The other thing what we could see is that the newer thing which is coming up is MRD and in CLL, and we can see that the MRDs are slightly higher when you add ibrutinib to BR. Obviously, the side effects are much higher when you do a combination. And again, we need to keep in mind about the atrial fibrillation, which is higher when we do the ibrutinib. Now, what we do in our setting, most of our patients, if they are fit, and in general, we use bendamustine rituximab. FCR is not a very, very commonly used agent. Probably in an institutional setup where we have very good supportive care, very young, fit patient, we would do FCR. But for most of the reasons, we are doing bendamustine rituximab. For unfit patients, rituximab chlorambucil has been a very, very good option in our setting. And if somebody cannot even afford rituximab, then probably chlorambucil prednisolone. The option for 17P has always been ibrutinib, though cost has been a constraint. These are some of the data available from relapsed refractory CLL, again from the AIMS group, where they had 70 patients of relapsed refractory, of which 18 patients were del 17P. And again, you can see that different kinds of treatments have been used in 17P. We have ibrutinib, bendamustine rituximab, R-CHOP, RCVP. The reason for using all these chemotherapy regimes is that we do not have access to targeted therapy. One is that only ibrutinib is available, and probably because of financial constraint. So genetic mutation, we are in most of the centers, we are slowly at least trying to do the TP53 mutation, because it makes a lot of difference to know whether it is 17P or not 17P, but rest of the mutation studies and the chromosomal analysis is not very commonly done. Between FCR and BR, most of the centers still use BR because it's easy and friendly, FCR in a very few setting. Chlorambucil with rituximab is still being very commonly used and quite popular. Sorry. And ofatumumab and obinutuzumab, again because of cost, we are not been using. Idelalisib and venetoclax is not available. CAR T cells obviously not available. MRD evaluation, I don't think any centers are clinically doing for any patients. So my last slide on conclusion. CLL is heterogeneous at presentation with indolent and aggressive disease. Diagnosis plays an important role, and I think at least we should be able to differentiate del 17 from the non-del 17. Studies from India have, some of the studies have shown that probably more high-risk features are seen in our population. The use of chemoimmunotherapy is declining, though the ibrutinib with the cost and generics available, probably more and more patients will go on to getting ibrutinib. So my last sentence is that management in CLL in India is still hampered by the unavailability of all this targeted agents, especially because of cost. Thank you. Thank
you, Biswajit, for highlighting the real world scenario or the real country scenario in India. I'm sure, I think the question and answer session will be at the end. And now I turn it over to Professor Agarwal to move forward. Thank you, sir.
Thank you, Dr. Kannan and Dr. Biswajit. A pleasure to invite Dr. Esha Kaul, Executive Consultant, Department of Hemato-Oncology and Bone Marrow Transplant at JP Hospital, Noida, UP. She will be chairing the next lecture, introducing the speaker and the subject.
Hello and a very good evening to everyone. It's my pleasure to now invite Dr. Mallikarjun Kalashetty. He is a consultant in clinical hematology, hemato-oncology and bone marrow transplantation at Comprehensive Cancer Center, Manipal Hospital, Bengaluru. He'll be discussing management of frail relapsed refractory CLL. And this becomes a very important question in now in a disease in which the median age is in the 60s. And when we are living in an era where we have so many options, newer drug therapies, with varied side effect profiles, cardiac toxicities. So even though, we are blessed to be having so many options, how to appropriately use them in older patients becomes a very important practical question. So I now invite Dr. Kalashetty to present the talk.
Thank you, Dr. Isha. My slides are visible, I hope. Am I audible?
Yes, sir. Please.
Yeah, thank you. So at the outset, I'd like to thank Dr. M.B. Agrawal, sir, team at AstraZeneca for the opportunity. Dr. M.B. sir would always want to keep to the time, so I'll try and finish my talk in time. So over the next 10-12 minutes, I'm going to talk briefly about management of frail patients of relapsed refractory chronic lymphocytic leukemia. So like we always do in all indolent non-Hodgkin's lymphomas, the first question that we should always ask when we have a patient in front of us is, should we treat or not treat? And that at least till now hasn't changed. So we must offer therapy to individuals of chronic lymphocytic leukemia in relapsed refractory setting only if they have one of these criteria for active disease: massive lymphadenopathy, organomegaly, progressive cytopenia, refractory autoimmune cytopenia, symptomatic extranodal involvement, or presence of one of these constitutional symptoms. So once we decide that the patient does indeed require treatment, then the treatment selection oftentimes would depend on multiple factors in relapsed refractory setting. So important questions being, which was the frontline therapy used? If a patient had received a chemoimmunotherapy, you would want to use the other agents. If the patient had progressed on say ibrutinib, then you would want to use a BCL2 inhibitor. So it depends on which was the frontline therapy used. What was the duration of first remission? What were the toxicities with the frontline therapy? And even when you talk about elderly patients, we must make sure a comprehensive geriatric assessment is done, cardiac, renal, and pulmonary functions are well assessed, and then we decide about the treatment. So indeed, it's also important to assess the disease. Again, we all know the importance of cytogenetics, of high-risk cytogenetic abnormalities in chronic lymphocytic leukemia, 17p, TP53 mutation, 11q, and complex karyotype abnormalities. We're also aware that these are more likely to be present in higher proportion of patients with relapse than in treatment-naive chronic lymphocytic leukemia patients. And of course, the elephant in the room for all our Indian patients is indeed affordability. Our previous speakers have alluded to that. There is a significant proportion of patients who live alone, target therapy, can't even afford a comprehensive diagnostic. So affordability, accessibility, the social support, and how easy is it for us to administer these medications at some part of our corner are indeed very important when we choose. I think Dr. Biswajit has already spoken to us about the importance of risk stratification, and we also know how dismal was the outcome when a patient had progressed on fludarabine about 10 years before. So those are some things that we need to know. So the prognostic importance of fish in chronic lymphocytic leukemia, deletion 17p and 11q universally did not do well till the advent of the newer modalities of treatment that we have. And TP53 mutation and deletion did the worst with whatever therapy we had till the advent of gluten tyrosine kinase inhibitor. So we also know the importance of assessing IGH2 mutation upfront. We know once a clone is deemed to be mutated or unmutated, this need not be repeated in the relapse setting because that doesn't change. So that is something that needs to be remembered. So Dr. Biswajit has already spoken to us with regards to the prognostic scoring. And what it does is it beautifully delineates patients into low, intermediate, high, and very high risk. And again, so just mere presence of TP53 mutation or 17p deletion would put patients into high risk and very high risk, and rightly so, because the outcome of these patients till very recently was universally bad. So there are various now legends that we have in chronic lymphocytic leukemia, and more are in pipeline actually. So the current challenge, as alluded to, is actually how best to choose a therapy, how to sequence them if needed, and in case the patients fail or progress or one or more of these molecules, how do we treat such patients? So that is the challenge. So I think some of these the trial data has already been looked at. So yes, so we'll start with the RESONATE. I think Dr. Biswajit has said this was a phase 3 study which was designed to compare the efficacy and safety of ibrutinib with ofatumumab, and it indeed showed a very impressive PFS benefit with ibrutinib. And what it also showed was ibrutinib patients did better even if they have the complex karyotype, unmutated IGHV or 17p, thus telling us that the ibrutinib can mitigate.
Sorry to interrupt you, sir, but we are not able to see your slides, sir.
You are not able to see my slides.
Yeah, you have to do the screen share, sir. Okay.
I don't know where you guys lost me, but can you see them now?
Yeah, it was on the same slide, no issues. Yeah, you can start from.
Yes. Hold on. Yes. So I think this is where we are. So I think Dr. Biswich has spoken to us about the RESONATE trial, which was trial to compare the efficacy and safety of ibrutinib. Ibrutinib did show the PFS benefit compared to ofatumumab, and it also showed the effect of ibrutinib in mitigating the poor prognostic implications of complex karyotype, unmutated IGHV, and deletion 17p. So I think he's spoken about the adverse events. About 10% of patients would develop atrial fibrillation, and the other toxicity being hypertension, and about 10% patients actually might discontinue medication in the first year. So this was the Australian group which tried to look at the efficacy of venetoclax in combination with rituximab when in comparison with bendamustine. So this is a Murano phase 3 study wherein the venetoclax was administered with rituximab for about 6 cycles, followed by continuation of venetoclax for a maximum of 2 years, compared to then standard of care bendamustine rituximab. And what it showed was an improvement in median PFS as well as slightly OS in VENAR arm. And the recent update of the same, the improvement in both PFS and OS seems to persist even at 5 years. And what is even more impressive is majority of these patients actually are in undetectable measurable residual disease, which indeed is very impressive. I think again, Helios trial has been alluded to by Dr. Biswajit. Here they try to see whether addition of ibrutinib to conventional bendamustine rituximab compared to placebo did better, and the PFS was much better in the ibrutinib arm. Of course, there was mild overlap in the other one, but what it also showed was this benefit was seen across the spectrum of chronic lymphocytic leukemia patients. Ascent trial, here the acalabrutinib, the second generation and much more specific bruton tyrosine kinase inhibitor, was compared to a comparator arm which could either be Idelalisib with rituximab or bendamustine with rituximab. And again, the acalabrutinib group did much better in terms of PFS compared to the comparator arm. And that improvement was also seen even in individuals who had 17p deletion and had unmutated IGHV clone. So that is something which kind of proves the efficacy of these in high-risk group. And even if you were to do a subgroup analysis and across all the subgroups, the outcomes were favoring acalabrutinib compared to the comparator arm. So atrial fibrillation was seen in about 6% patients, hypertension in about 5% patients, much less than what we saw with ibrutinib in RESONATE trial really. So headache is a common adverse event of acalabrutinib, seen in almost 1/3 of the patients who are on this, at least initially. So this was a study which tried to see if we can achieve deeper molecular and MRD negative responses when we combine ibrutinib with venetoclax. Very interesting study indeed. So what they did was the first 2 months individuals were put on ibrutinib, and then following 2 months of single agent ibrutinib, they would add venetoclax, and they would assess the MRD4 or 1 in 10 to the 4 of MRD negativity. And individuals who would achieve MRD negativity at 6 months of combination of the two agents, they would stop the therapy after another 6 months of treatment. So the primary endpoint actually was to assess for this at 12 months, and almost half the patients at month 14 had MRD4 by flow cytometry in this study. And what it also showed was the cumulative MRD negativity at 12 months was almost seen in 46% of patients, thus telling us that at least some of the patients who achieved deeper response could be stopped from the therapy, and this therapy could be made finite. So that is something that leads to various other trials in the similar way. So there are various ongoing phase 3 trials in chronic lymphocytic leukemia, and that is exciting. So this table shows us a subtle difference between ibrutinib and acalabrutinib, telling us that the acalabrutinib is a selective molecule, and that is the reason why some of the toxicities seen with ibrutinib are not very common with acalabrutinib. So the other modalities of therapy, like any hematological malignancy, is a CAR T-cell therapy, and that has also been studied even in patients of relapsed refractory chronic lymphocytic leukemia. But I'm sure for that to be made available to some of our Indian patients, we still are time away. So I think again, Dr. Biswis has alluded to the fact that the acalabrutinib, ibrutinib, venetoclax, they do figure as a first-line preferred therapy, both in fit and frail patients, and also both individuals who have 17p or who do not have 17p. So I think that is a way ahead, really, and most of the guidelines would actually confirm the same thing. So if one has to choose venetoclax-based therapy over Bruton tyrosine kinase inhibitor therapy, essentially you would choose patients who have failed or progressed or are intolerant to Bruton tyrosine kinase inhibitors, or if the patient requires intense anticoagulation, have high risk of bleeding, or some of them, despite being on multiple antihypertensives, if they have high blood pressure, in such group of individuals, perhaps Ven or Ven-R-based regimes are preferred. And if individuals have significant renal dysfunction, are on strong CYP3A inhibitors, or have failed Ven-based therapy, then would choose Bruton tyrosine kinase over that. So while we have reviewed all this data and wait for some of these medications to become affordable for majority of our patients to take, I think all of us will continue to use conventional chemotherapy, chemoimmunotherapy, anti-CD20 monoclonal antibodies, steroids with other conventional agents, and very rarely, even today, we may have to resort to these modalities of treatment, at least for symptom care and making sure the patients have good quality of life. So I think I'll stop there. Thank you for patient hearing, and I will hand over the session to Dr. Mohan Agarwal, sir.
If I can just ask a quick question, specifically because we are talking about relapsed refractory and we are talking about second generation BTK inhibitors. If a patient has progressed after receiving a first generation BTK inhibitor, what are the chances that they will respond to a second generation? So, do the trials guide us about this question?
So, Dr. Isha, there are few trials wherein they have said, they have seen actually patients who could not tolerate ibrutinib when they were treated with acalabrutinib. At least 50 to 70% of them tolerated the medicine well, and they achieved responses. But with regards to its efficacy in individuals who have failed ibrutinib, I don't think we have robust data, at least to my mind. MBSR may intervene.
Yeah, that's also my understanding that the answer to this question is not very clear. I haven't been able to find what the patients who were on second generation BTK, if they had progressed on first generation, were they allowed to be on study or not? So hopefully in some of the subsequent talks that question will be answered. Thank you very much.
Thanks to Dr. Isha Kaul and Dr. Mallikarjun. We move on to the third lecture, and to chair this is Brigadier Dr. Satyaranjan Das. He's Professor and Head, Pediatric and Clinical Hematology at Command Hospital at AFMC, Pune. Over to Brigadier Das.
Sir, thank you very much. It's my pleasure to invite Dr. Abhay Bhabe. He is a very well-known hematologist in Mumbai. Sir will be speaking on challenges in first BTK inhibitor and chemoimmunotherapy in treating relapsed and refractory CLL patients. I remember when we moved from the oral chlorambucil to chemoimmunotherapy, there are two challenges, both clinical and financial. And presently, when we moved from the chemoimmunotherapy to BTK inhibitor, that is first BTK inhibitor, we also face similar problems like clinical as well as financial problems. I think Dr. Abhay Bhabe will be discussing all those, what are the clinical adverse effects we faced, both with chemoimmunotherapy as well as with the first generation BTK inhibitor. Now over to Dr. Abhay, sir.
Thank you very much, Dr. Satyaranjan Das. I hope I'm audible and I hope my slides are being seen.
Yes, sir.
Yes.
So at the outset, I'll thank Mumbai Hematology Group, Dr. Agarwal, and AstraZeneca for the opportunity to speak on a topic which I found a little bit difficult and challenging to talk on challenges with CIT and first generation BTK inhibitors. I'll have to admit that while we're talking of relapsed CLL, There'll also be some relapse in the slides between the other two speakers and me. The reason why we are discussing about challenges with CIT and first generation BTK is because the management of CLL has undergone a revolutionary change, and these novel agents, not only in the relapse setting but also in the upfront setting, has made a huge impact on the management of CLL. You've seen the slide, and whenever a patient has a relapse of CLL, we first see whether the patient is really symptomatic and needs immediate therapy or needs counseling in order to tell what the proposed plan would be for that patient. But don't forget, the patient's already spent a good amount of money, has been exposed to certain drugs. We'll have to see which is the frontline treatment, what was the toxicity of those agents, what is our patient's fitness, were any organs damaged as part of disease or frontline treatment. What is his genetics now? Is the genetics 17p or non-17p? Does he have a large amount of bulk of disease? Does he have immune cytopenias? Then does he have the finances to be able to handle a relapse situation? Does he want oral hospitalization? Is he scared of corona? He doesn't want to come to hospital. He'll want oral therapy from home. And we'll have to look at how he can handle the cost and whether there are caretakers to take care of this patient. So it's very easy to discuss protocols, but first is we have to counsel the patient as to what's going to happen next. If now the patient is on the same page as you and either fits the bill for treatment or is ready for treatment, then we can go ahead. So it's clear from NCCN, there's no doubt that whether it's a patient above the age of 65 or below the age of 65, whether there's comorbidity, whether there's no comorbidity, there's no doubt that the preferred regimen is the novel agents, and in that the BTK inhibitors take priority. But as alluded to earlier, that we in India still use BR, chlorambucil with R or Len with R. So we are using rituximab with some chemotherapy, rituximab being the backbone. But we all know that the responses are not very good. Even in the patients who are younger, we have no choice because sometimes they can't afford the novel agent. So we end up using the same combination. But if the challenge is to use a BTK inhibitor in such patients who are relapsed CLL, is there a way that we can overcome this challenge? So thanks to Indian pharma, we are able to overcome this challenge, and a large number of our patients have been able to access ibrutinib, not only in the older patients who are frail with comorbid, but also in the younger patients who either are not desirous of coming to hospital or not wanting to take any chemotherapy because of poor experience in the past. So thanks to this pharma, to our Indian pharma, generic of ibrutinib is available for therapy. In the right-hand side of your slide at the bottom, you'll see another combination which has been alluded to already, which is the bendamustine rituximab, our good old BR, added with ibrutinib, and it has made a huge impact, and we'll allude to it soon. If you were to believe what Halleck says, then if your relapse has taken place after 3 years, you still have the option of using the first line of treatment, as long as your genetics still favor it. But if it is 17p deletion, which has come as part of the relapse, then maybe the option of going to first line of treatment, which is not novel agent, may not be a bright idea. For the other group of patients who have relapsed and who now have deletion 17p or TP53 mutation, there's no doubt that the preferred regimens again are the BTK inhibitors. Here comes the challenge. In India, for those who can't handle ibrutinib, the response to chemotherapy is also poor. And if you now look at the recommended other regimens which are there, you'll see many of the standard regimens which you alluded to earlier have now dropped off because the responses are not very good. Again, thanks to Indian pharma, we have ibrutinib available for this group of patients also, and we still show responses. Do we know whether they respond? A group of 40 CLL patients, 50% of them who had deletion 17p, if we used our good old rituximab, which is available as generic with us, and ibrutinib, the overall response was 95%, with 23% patients still going into CR. Yes, 50% discontinued, but for those who remained on therapy, still they had a good response. Overall, the progression-free survival was 45 months and 32 months for deletion 17p, which has never been got with chemoimmunotherapy. So it appears that the addition of a novel agent like ibrutinib to rituximab gave us a durable remission in including patients with high-risk CLL, that is deletion 17p. Therefore, this is another challenge that we have overcome in the management of relapsed CLL. you've been shown the Helios trial, and you've shown that when a novel agent like ibrutinib was added to BR, the progression-free survival was better, significantly longer, and it had a statistical value. But yes, I agree that the overall survival was not very different from just the BR. But if you allowed the patients to take ibrutinib for a longer period of time, then the study showed that the median overall survival was slightly longer, may not have received a statistical advantage. And the overall response rate was excellent. And the CR rates were 5 times higher than the BR. And there were patients of MRD negative response, and that was higher in the novel agent with BR than the BR alone. Therefore, the addition of ibrutinib and bendamustine rituximab, all available as generic and in the realm of many patients in previously treated or relapsed CLL, is still a very good option to use in our country. So the change in paradigm in CLL, what we see in the West, we also have a similar paradigm which we can use in our country. If you look at chemoimmunotherapy, where the goal was eradication of disease with a finite line of treatment, giving us a higher CR, especially in patients who had the IGVH mutation, especially with the FCR, we got a higher CR, very good MRD negativity. 70% of patients remained free of disease for a prolonged period of time, even up to a decade. Therefore, they had a long progression-free survival. But the problem with FCR is most of our patients were unable to take 6 cycles. Many of them dropped off by the 3rd or 4th because of cytopenias, infection, especially tuberculosis and fungus. And therefore, for those patients who have a poorer risk of genetic profile at the time of relapse, or whose physical fitness is not adequate, there is no doubt that the BCR inhibitors is the way to go. The goal of therapy with these inhibitors is disease control by using the drug continuously so as to get a sustained response and a long progression-free survival. So it appears that just like in the West, with us also, the best option for relapsed refractory CLL would be the BTK inhibitors because they're available with us, especially the first generation one, ibrutinib. But at the same time, the role of chemoimmunotherapy has diminished but not gone, because you saw in the Helios trial that addition of BR to ibrutinib made a huge impact. Therefore, in India, we are very happy and we are enriched by the fact that a combination of this can still be used to gain durable responses in our patient. But the problem, challenge number 3, which I see, is how to ensure compliance on patients who are taking ibrutinib, because it does have side effects and adverse events. And then your whole idea of a sustained response and long progression-free survival was based on the fact that you continue to take the drug. How do we do this? So there is a way of overcoming this challenge also, and I'm going to show you data of dose reductions and duration modifications. But before I come to challenge number 3, can I just tell you give you data that does really ibrutinib work in relapsed refractory CLL with high-risk disease, including deletion P17P. I'm showing you 2 articles here. The first one of 56 patients, relapsed refractory CLL with a 28 days on, 7 days off, and the other one which has got a daily continuous dosing. You can see that the response has been good. It works. In the second paper, ibrutinib was seen in 85% patients who had relapsed refractory, and the majority had high-risk disease. And you'll see here there were 2, 420 versus 840 milligram comparison. Interestingly, both were tolerated well. We don't see that happening much in India. But you'll see that the overall response rate between the 2 was similar. It was 71%. Therefore, 420 seemed a good dose for us even in India when the patient have a high-risk disease. And the response was independent of clinical and genomic factors, including advanced stage disease, the number of previous therapies, and the presence of deletion 17p. And a couple of years down the line, the estimated progression-free survival rate was 75%, and the overall survival was 83%. These results show that ibrutinib yielded a durable remission in CLL with relapsed refractory high-risk disease, so it works. This is a complex chart, and I'm sorry, but we'll go through it quickly. The above the blue line is the use of novel agents in first line, and below the blue line is in relapsed refractory state. If you look at the Voyage's study where ibrutinib versus ibrutinib with rituximab and BR was seen, you'll see over here. I'll try to get my laser pointer on. You'll see here that there is a superior progression-free survival for ibrutinib and for ibrutinib with rituximab. Even the monotherapy of rituximab worked very well. This is in frontline setting. You look at BR had a CR of 26%, a progression-free survival of 41, and a great 2 years overall survival. Similarly, if you look in this trial, which was ibrutinib with chlorambucil, you'll again see that as monotherapy also, ibrutinib has done very well. If you look at the trial between the two, you look at the FCR with ibrutinib, you'll see that both were similar in their outcomes, but the problem with FCR was early deaths. If you go to the relapse protocol, suddenly things change. BR, which was doing well before, seen here, is suddenly not doing as well. This highlights the fact that chemotherapy alone in a relapse state may not be a good idea. But look at when it was combined with ibrutinib, suddenly we got a good progression-free survival. And our progression-free survival, overall survival improved. When you had the same thing of BR compared with another set of treatment, which is venetoclax with rituximab, again you saw bendamustine and rituximab didn't do as well, and the novel agents did better. And similarly in the idelalisib with BR, again BR did not do well. It's suggesting that in relapsed disease, while India favored BR, it was not the protocol of choice. It may be more of a palliative intent than the intent to treat for a prolonged period of time. And the novel agents was the way to go in these cases. So I'll come back to my challenge, which I said earlier. And the challenge was of ibrutinib toxicity and its management, how to ensure that we continue. Really, the toxicities are similar, but in a relapse state, bleeding rates, atrial fibrillation is higher. The thrombocytopenia is deeper, and infection, especially pneumonia, is more. But there is a way to overcome this challenge also. Remember, the grade 1 bruising is frequent, but it is harmless. Don't add both antiplatelet and anticoagulation to ibrutinib. Just use one of them. If you're doing a procedure, stop ibrutinib 3 or 7 days before and after the procedure. Your risk of bleeding will come down. If there's atrial fibrillation, use DOAC over vitamin K antagonist, and you should do fairly well. Yes, there can be hypertension even later on during therapy, but with medications, it can still be brought under control. And the first 1 year is the most difficult year, especially the first 3 months. Keep a good count. Watch on the blood counts, and you should be still able to overcome the problems of ibrutinib in a fairly good number of patients. But having said that, dose reductions, dose holding, and dose discontinuation is an issue with ibrutinib. There's no doubt about it, and there's data here in front of you. If you look at comorbidities, the comorbidities are associated with an increased incidence of reduction of these dose and discontinuation. And with the comorbidity index going higher, then even the progression-free survival and overall survival start reducing, including in the novel agents era. So in the discontinuation of these agents, especially ibrutinib, has been even higher in the real world as compared to the trial. And especially if you get these adverse events, the EFS and the overall survival shorten, especially when you're dealing with issues like bleeding or atrial fibrillation. So there's no doubt there's a problem or a challenge with ibrutinib in terms of its adverse events and its side effects. And if you see all the trials, whether it was the Resonate, whether it was Resonate 2, whether it was another trial of phase 1B, the PCYC, there's no doubt that there are side effects and there's a significant proportion of patients. In fact, in a real world data, a review of the adverse events experienced by this number of patients showed that the incidence of these events in a relapse state is very high. And many of these patients has to discontinue treatment. Almost 50% were going to discontinue treatment because of that. So we also found out from this real world data, there were things which were not included in the first trials. So pneumonitis, drug-induced colitis, events which took place in the real world. So there's no doubt there's a problem with it. But the real world analysis also showed that there was no doubt equivalent outcomes in patients receiving reduced dose, which is time limited with dose interruption therapy. And I'm going to show you some data. Retrospective cohort of this 197 patients who had large number of relapsed patients from 3 academic centers, the authors were unable to find a difference in the progression-free survival or overall survival over 5 years of follow-up for a median reduced dose of 4.3 milligram versus 5.1 milligram per kilogram. If you take an average Indian weight as 60, we are still looking at about 240 milligram. That means 2 capsules of ibrutinib per day, which will still do the job. Another data with 70%. Sorry, I'm out of time.
Yeah.
Okay, I'll stop after this slide.
Thank you.
And over here, you'll see that in the retrospective data, 70 patients, again, majority patients were relapsed refractory CLL. You'll see that even with the lesser dose of 150 at some points of time and trying to go up as much as possible till they were unable to tolerate and coming down also did well for our patients. The Lymphocytic trial also in a 30-month follow-up data of the Swedish compassionate use showed that even if there's a relapse disease and there was dose reduction, still the patient did not have a major impact. Can I just say that just like we saw with dasatinib 50 milligrams doing well, it's quite likely that even ibrutinib with a lesser dose may be doing as well without the side effects which make us want to discontinue the drug. The other challenges that I wanted to bring up was about resistance to ibrutinib and what to do in terms of sequencing. We are very thankful that two drugs which will be coming into our market might make a difference. Venetoclax is available to us, although extremely expensive. But just imagine if it were to come as a generic, it will make a huge impact in the Clarity trial, which was shown earlier, where ibrutinib was combined with venetoclax, and a huge impact in terms of MRD status. Almost 46% were negative. And of course, acalabrutinib, which will soon be coming to the market. And we look forward to Dr. Sarit to tell us more about these agents, especially venetoclax, especially acalabrutinib, which will be hitting our market soon. So I thank you for the opportunity, and I'm sorry I've overstepped my time.
Sir, actually, as you can see, Dr. Abhay recently brought out the challenges in relapse refractory CLL management. And the question now asked will be, I think, subsequently, or it's already delayed. So now I hand over to Dr. MB, sir.
Thanks, Brigadier Das and Dr. Abhay. Now I invite Dr. Shekhar Patil, Consultant Medical Oncologist at Bangalore Institute of Oncology, Bangalore, to chair the guest speaker from abroad.
Thank you, sir. Can you hear me, sir, please?
Yes.
Yeah. Thank you very much, sir, for the invitation. And the next topic for the discussion will be on the optimal selection on the second generation BTK inhibitors in treatment of relapsed refractory CLL. So to address this talk, basically when you are using the first generation BTK inhibitors, we have got some limitations in terms of the toxicities, particularly the atrial fibrillation, thrombosis. So does the second generation TKIs can overcome all these things, maintaining or improving the efficacy, is what our guest speaker today, Dr. Sarit Asin, will be speaking on. Dr. Sarit Asin is a hematologist in the Jewish General Hospital, Montreal, and she is also an associate professor in the Department of Medicine, McGill University, Montreal Hospital, Canada. And she has got a lot of publications, and she conducted more than 100 clinical trials in the treatment of leukemias and lymphomas. And she has participated in several studies in the newer treatment of CLL with BTK inhibitors, PIK3 inhibitors, BCL2 inhibitors, and many other novel CD20 molecules. And she holds a clinical scientist award in the province of Quebec in Canada. And she will be speaking to us on this topic. It is over to you, Dr. Sarit Asin, for your talk.
Thank you very much. I thank all of you for inviting me to present today. It's really quite an honor and quite a pleasure to hear how you are able to manage CLL in India. I've learned a lot of things in the last hour, so I will reflect on those during my presentation. I will. Am I able to share my screen?
Yes, you can.
Sorry, that.
Ma'am, there is a share screen button.
Yeah, yes. Okay, here we go.
Yeah.
Okay. Okay. So yes, my talk will focus largely on acalabrutinib, but as I said, I looked up some of the publications on CLL incidence and prevalence in India and other things, and I've learned some things today. So as I understand it from this publication, I guess the distribution of lymphoid malignancies is a little bit different between North America and India. Here are the data for the US, but Canada is very similar. So although we both see a lot of large cell lymphoma and follicular lymphoma, most common lymphoid malignancies, I think we in North America may see a little bit more CLL. I'm not sure of the reason for that. And differently from us, you see a little bit more of the T-cell related lymphoid malignancies. The other difference is that the median age for diagnosis of CLL in North America is about 72 years, and it's a little bit younger in India. Probably similarly, our patient populations have high rates of comorbidities. Most patients with CLL will require treatment at some point in their lives, and so we follow our patients regularly, even though many of them are asymptomatic. And so this is what I'll be talking about, largely about the ASCEND trial, which is the use of acalabrutinib in relapsed refractory chronic lymphocytic leukemia, some of the safety data related to that, and give you some information on acalabrutinib, but also highlight some of the things that some of you have said. So the NCCN guidelines were already referred to by two other speakers. And for relapsed refractory CLL without 17p deletion, the right agents to use are acalabrutinib, ibrutinib, and venetoclax and rituximab in terms of both tolerability and efficacy as measured by progression-free survival. And then other regimen, and this is regardless of age or comorbidity or patient frailty. So these drugs are, based on their superior efficacy, should be used in all groups of patients. We rarely or almost never use idelalisib and rituximab, which idelalisib is a PI3 kinase inhibitor. Duvelisib is not available in Canada, and idelalisib is associated with a lot of diarrhea, risk of infection. It's a difficult drug to administer, so rarely used. We never use, or almost never use, chemoimmunotherapy in the relapse setting anymore in Canada because of the availability of these drugs, acalabrutinib, ibrutinib, Ven-R, which is really quite different from what you are describing in India. On the other hand, bendamustine rituximab was never really popular in Canada, particularly in Quebec, because it was very costly and the benefit was not considered to justify the risk. And now that it's generic, we have the newer agents that seem to be more effective. When a patient has a 17p deletion or TP53 mutation, again, the choices of treatment in the relapse setting are acalabrutinib, ibrutinib, and venetoclax and rituximab, all of which are available to us. Some of you have talked about ibrutinib in combination with bendamustine and rituximab. I participated in the Helios study, and it's true that the CR rates are higher, but if you look at the PFS curve for that trio, it's really not so different from ibrutinib on its own. And so that is not a regimen that is popular in North America. Ibrutinib, bendamustine, rituximab is almost not used, and ibrutinib alone is the therapy of choice. As the first BTK inhibitor, we'll talk about acalabrutinib, and it's more common use now in the country. In addition, we don't combine ibrutinib with rituximab. The data are not strong for that combination, and although you may have deeper responses, again, it doesn't seem to impact on progression-free survival. And ibrutinib is not a drug that gives CRs, but it does, and BTK inhibitors in general, are not drugs that induce complete remissions, but they do give a significant progression-free survival advantage over chemoimmunotherapy or chemotherapy on its own. So that's a difference from the perspective I've heard today. We don't give a lot of rituximab, we don't give a lot of chemotherapy in the relapse setting. So acalabrutinib, to get into a little bit more detail, is a BTK inhibitor with high specificity for BTK, and this is the kinome map on the right that you see. And in comparison to ibrutinib, it has a lot less off-target kinase inhibition. And that's, initially with the discussions around this drug was supposed to be associated with less adverse events. And you will see that the adverse event profile of acalabrutinib is very favorable. But we don't know yet clearly how it differs from ibrutinib. And we're awaiting a randomized phase 3 study in relapse CLL, which compares acalabrutinib to ibrutinib. So this is the development timeline for acalabrutinib. First phase 1 study was in treatment-naive CLL, and the there is a CL208 study which uses acalabrutinib in patients who are intolerant to ibrutinib. So somebody asked the question about, and I'm sorry that I don't know all your names, but about using acalabrutinib in patients who have progressed on ibrutinib. So if there is a progression on ibrutinib, it's often associated with a mutation in the cysteine 481 domain, which is where the BTK inhibitor binds, or in the PLC gamma, which is a downstream enzyme effector of the effect of BTK inhibition. And so acalabrutinib or other BTK inhibitors of the second generation are not effective in the context of CLL with a progression of this sort. So none of the trials that looked at the acalabrutinib trial, for example, and the zanubrutinib trials, which is another BTK inhibitor of second generation, did not accept patients who had progressed on ibrutinib, just to answer that question. There are new BTK inhibitors that are being developed and are in clinical trials now that are effective in the context of a C481 mutation. And so those drugs are being tested in patients who have failed a first or second generation BTK inhibitor. I hope that answers that question. Then there is the Elevate. So the Ascent trial is the one we're going to focus on, relapsed refractory CLL with acalabrutinib, and Elevate TN is the frontline study. And finally, there is the head-to-head comparison of acalabrutinib to ibrutinib, which is really a very brave effort on the part of AstraZeneca. I personally am very interested in knowing what those results will be. So acalabrutinib is called Calquence. That's the trade name. It's given as a oral dosing, 100 milligrams BID, with or without food. With this BID dosing, you have high and sustained BTK occupancy and inhibition. And this is the Ascend trial. So Ascend is a randomized phase 3 study comparing acalabrutinib monotherapy to either idelalisib and rituximab or bendamustine and rituximab. And it was the investigator's choice for that control arm. We participated in the study. The patient could be, the investigator could select the control arm that he or she wished to put their patient on. This had to be done prior to randomization. The primary endpoint of the study was the independent review committee assessed progression-free survival. And the secondary endpoints are the usual overall response rate, duration of response, PFS as assessed by investigators, overall survival, etc. Patients had to be adults. They had to have received at least one prior therapy, had a creatinine clearance of 30 or higher, an ECOG performance status of 2 or less, adequate hematological reserve, hepatic and renal as well. Patients could be on anticoagulation, but not on warfarin or any vitamin K antagonist. And they could not have received a prior BTK, PI3 kinase, SYK inhibitor, or BCL2 inhibitor. And patients with significant cardiovascular disease were excluded. Patients previously treated with bendamustine were allowed on the trial if they had had a remission to their previous bendamustine lasting at least 2 years. So these are the baseline patient characteristics. They're well balanced between the two groups. The median age reflects the median age of patients with CLL, a little bit younger actually, and most of the patients had received 2 or more prior therapies, and they'd been treated with a array of treatments that are commonly used in the frontline setting. At least, from what I understand, you don't use a lot of FCR, but in North America, that was used quite often in younger patients. So a lot of patients had received a purine analog, alkylator therapy also, and bendamustine in 1/3 of the patients. Most patients had received rituximab or another anti-CD20 antibody. And as you can see here, the study included a considerable number of patients with TP53 mutations and 17p deletions, so at least 25%. There's often overlap between TP53 mutation and 17p deletion. Most of the patients had unmutated IGHV, and a third had complex karyotype. And this is the updated data. So the first report was the, as I said, the independent review committee assessment of progression-free survival that was reported after a median follow-up of 16 months and published in JCO. This is the update from ASCO at a 22-month median follow-up, and you can see that the progression-free survival for acalabrutinib was not reached. And for idelalisib, rituximab, and bendamustine rituximab, the median duration of response is 16.8 months. This is a significantly different difference in progression-free survival with a hazard ratio of 0.27 so a 73% risk reduction. So about 82% of patients on the acalabrutinib arm do not progress at this median time of follow-up. I should say that the majority of patients received idelalisib and rituximab, with only a few receiving bendamustine rituximab as a control. And here on this PFS curve, you can just see the difference between acalabrutinib and each of these regimens. Again, a significant and stark difference between the two. So based on this, most of us do not continue to give bendamustine and rituximab. And idelalisib and rituximab is a highly unpopular regimen because of the associated toxicities. The subgroup analyses have already been shown to you by another speaker, but I'll go over them again. All patients in all subgroups benefit more from acalabrutinib than from the other control regimens. So that's older patients, patients with higher stage disease, patients with bulky disease, those with and without 17p deletion and TP53 mutations. And here again, IGHV mutational status does not impact on the response to BTK inhibition, similarly for complex karyotype. So moving on, we have clear efficacy with acalabrutinib. It's a highly effective therapy in relapse refractory CLL in comparison to standards. What is its toxicity profile like? So these are the common adverse events occurring in 15% or more of patients. As you can see, most of them are grade 1 and grade 2, and they are bleeding and headache. We'll get into a little bit more detail about some of these toxicities: neutropenia, diarrhea, upper respiratory tract infections. And neutropenia is seen with acalabrutinib, but to a lesser extent than with idelalisib and rituximab, as you can see here. The other adverse events that were common and occurring in 10% or more patients in the study were fever, pneumonia, thrombocytopenia, and fatigue. And these rates are lower in most cases for acalabrutinib than for the other control arm therapies. Cardiovascular toxicity of BTK inhibitor is a subject of great interest. We've learned a lot with ibrutinib. The rates of atrial fibrillation are about 5 to 10%, and they seem to increase with time or to be more frequent in older patients. So this looks at the risk of cardiac complications in patients who receive acalabrutinib in comparison to the control arms in the study. And so the atrial fibrillation rate in ASCEND was 6%. Compared to 3% in the other two arms. No cases of ventricular tachyarrhythmias were noted, and that's in contrast to ibrutinib. And hypertension seen in 5%, no different from the idelalisib and rituximab containing arms. Bleeding occurred more frequently with acalabrutinib, but serious bleeding was was about 3% of patients. In terms of tolerability, the rates of discontinuation of acalabrutinib were 14% compared to 59% with idelalisib and rituximab, and 17% with bendamustine and rituximab. But recall that acalabrutinib is given as a continuous therapy, whereas BR is limited to 6 cycles. And dose reductions were rather infrequent for acalabrutinib at 4%. So, conclusion, the ASCEND study confirms the findings of the interim analysis and support the favorable efficacy and safety of acalabrutinib versus standard of care in relapsed refractory CLL. The progression-free survival is significantly prolonged with acalabrutinib, and the median overall survival and duration of response were not reached with acalabrutinib after a median follow-up of 22 months. Acalabrutinib seemed to be more tolerable than the other regimens, with fewer patients on acalabrutinib discontinuing therapy. And overall, the data support from this study support the use of acalabrutinib for relapse and refractory chronic lymphocytic leukemia. So I prepared a case for you about our patient who we included in the study. It's a bit of a complex story. He's a 77-year-old man who was diagnosed with CLL in 2009 without a 17p deletion. He has a history of coronary bypass surgery, was on aspirin, antihypertensive, and lipid-lowering agents. His first treatment for his CLL back in 2009 was rituximab and fludarabine, and he developed a severe autoimmune hemolytic anemia So his treating physician didn't want to continue to take care of him. She just thought he was too much to handle. So she referred him to our center. We had a clinical trial of bendamustine. And so in 2010, we gave him that for progressive lymphadenopathy. Again, no 17p deletion. And he received 2 cycles, and after that developed another severe autoimmune hemolytic anemia, and so we had to stop the treatment, gave him steroids and rituximab. He had 2 more episodes of autoimmune hemolytic anemia, and during one of them developed a deep vein thrombosis and a pulmonary embolism and had to be put on low molecular weight heparin and then an oral anticoagulant, not warfarin. In 2017, he had progression of his CLL, and he was given RCBP, which is cyclophosphamide, vincristine, and prednisone, and rituximab for 6 cycles by a colleague of mine. At the time, we did have access to ibrutinib, but because the patient was on an anticoagulant and had some cardiac history, my colleague who wasn't around at the time felt hesitant to give him ibrutinib, and I agreed with that choice. So this is the treatment that he received. He had a transient response, and in 2018 had a progression of CLL with a rising white count, progressive adenopathy, and a persistent but mild and controlled autoimmune leukemia. We had no 17p deletion, and so the ASCEND trial was available at our center. I selected BR for him, knowing that he had a response in 2010, and that's what he received for his treatment. He was randomized to BR, to which he had a partial response. But then 6 months later, he had progression of disease with enlarged cervical nodes and lymphocytosis, and this time had presence of 17p deletion, and he was crossed over to acalabrutinib. He tolerated this treatment very well, except for a transient headache. He had a partial response and did quite well until he developed a loculated pericardial effusion, a cause that we don't know. We held the therapy, we drained the effusion, it was a bit hemorrhagic, and then we restarted the acalabrutinib and were able to continue that until he progressed with a Richter's transformation and passed away. So this case highlights a couple of points about the use of acalabrutinib in relapsed CLL. Headache is a common manifestation. Most of them occur early, so the median it occur in the first 6 months, can be treated with Tylenol or caffeine. We often tell our patients to just drink coffee or Diet Coke, something that contains caffeine. The median duration is about 20 days, and most of the time it's self-resolving, so it wouldn't be a reason to stop therapy. Another issue that this brings up is the risk of cardiac disease. So I showed you some of the ASCEND data already. This is more of a summary data of several studies looking at acalabrutinib. So the ELEVATE-TN is the treatment-naive population. ASCEND is the study we discussed, and the CL001 has the longest follow-up. It's the first study. And as you can see, the rates of cardiac events are very similar between the groups. The rates of atrial fibrillation remain low, even with longer follow-up. So 5% in the CL001 study, which has the longest follow-up. There were no cases of ventricular tachyarrhythmias, as I previously said. So, I mean, we consider this therapy relatively safe for our patient despite his known history of coronary artery disease. What about antithrombotic agents? I think it's very important to raise this point. I mean, I don't know how common the use of antithrombotics is in India, but for us, a lot of our patients are on aspirin. A lot of our patients are on anticoagulations for prior pulmonary embolism or other reasons. And so it is a risk to give these sorts of patients BTK inhibitors, but it can be done as long as it's not warfarin. And it should be done. Patients should be monitored closely when they are on anticoagulation. And in the context of surgery, you have to hold your BTK inhibitor prior to and after surgery for a few days in order to ensure that there isn't a higher risk of bleeding. So we do it if patients are on low molecular heparin or a DOAC, and we monitor them very closely. And if they're on aspirin only plus a BTK inhibitor, it's probably safe not to worry. But once another antiplatelet agent is added for a stent, cardiac stent, for example, that's when you have to really keep a very close eye on your patient. So additional considerations about acalabrutinib. It should be managed in a similar way to ibrutinib. In other words, for the first and second occurrences of grade 3 AEs such as thrombocytopenia, neutropenia, or non-hematological AEs, you can stop the therapy, allow the AE the adverse event to resolve, and then resume the treatment. But if there is a third occurrence, then you have to consider dose reduction, or you need to dose reduce from 100 milligrams BID to 100 milligrams a day. And if there is a fourth occurrence, that would be a time to discontinue the acalabrutinib. I'm showing you these data because right now in Canada, most patients are getting acalabrutinib in the context of having been intolerant to ibrutinib, and I'll show you some cases. And I suspect that given that acalabrutinib is approved in India, if you have access to the therapy, you may be using it as we have. So this study is in relapsed refractory CLL. There's 60 patients who had previously received ibrutinib but were intolerant to it due to a persistent grade 3 or 4 adverse event, or a grade 2 adverse event lasting longer than 2 weeks or recurring more than twice. They needed to have sort of stopped the ibrutinib or progressed on the ibrutinib, and then, they'd have to stop the ibrutinib, shown progression once off the ibrutinib, and then they could be put on acalabrutinib. So they aren't resistant to ibrutinib, they just progressed because they were taken off. They would receive 100 milligrams of acalabrutinib twice a day, and the primary endpoint was overall response rate, and then also looking at adverse events. So, like I said, there were 60 patients. This is the patient outcome on this study. I won't go into the detail here. The response rates were fairly high in this group. So if you are on ibrutinib, can't tolerate it, and go on to acalabrutinib, you can have very good overall response rates and duration of response. And interestingly, for the patients who had, these are sort of the key adverse events, are the ones that we mostly stop ibrutinib for: atrial fibrillation, diarrhea, arthralgia, rash, and bleeding. So for a lot of these, they would not recur when the patients would be put onto acalabrutinib, or they would occur with a lesser severity. So this gives quite a bit of support to making that switch from ibrutinib to acalabrutinib in the context of intolerance. A little bit more safety data. I don't know how much time I have, but I will just quickly review these data with you. So acalabrutinib, the pooled safety data comprise 1,040 patients from multiple studies of not just CLL, but other B-cell malignancies, with a median follow-up of 25 months. And as you can see, these are the common adverse events associated with acalabrutinib across diseases: headache, diarrhea, upper respiratory tract infection, bruising or bleeding, and some arthralgia, as you can see also here. If you look at the AEs of interest, particularly the neutropenia can occur, and anemia. Pneumonia is a common one, and thrombocytopenia, and hypertension as well. But the rates are fairly low for these. Finally, looking at the risks of hemorrhage. So the hemorrhage is in general a common problem, hemorrhage being any grade bruising, but major hemorrhage occurred only in 3.6% of patients. Atrial fibrillation in about 4% of patients, which is different from ibrutinib, which seems to have a bit of a higher rate. Hypertension also can be seen, but again, lower than what is seen with ibrutinib. And so in overall then, acalabrutinib appears to be a very tolerable therapy based on this pooled analysis. Only 9% of patients discontinued the treatment due to adverse events, and were able to sustain a high dose intensity of 98.7%. The most common adverse events to retain then are headache and diarrhea. The diarrhea is self-limited, just like the ibrutinib. In terms of the AEs of special interest, atrial fibrillation and hypertension were not that frequent and of low grade. So I do have some cases to review. Shall I go over those now? Yes? Okay, so these are our patients that we have put on acalabrutinib, or that I have put on acalabrutinib recently. This is a 74-year-old man with a history of hypertension, hyperlipidemia, and diabetes, who's on an array of medications that you can see here, including aspirin. He was diagnosed with CLL in 2015 and was observed until 2017, when he started to have a progressive anemia with a positive direct Coombs test, but no other signs of hemolysis, no 17p deletion, no 11q deletion, and we started ibrutinib. About 2.5-3 weeks later, we had to hold it for neutropenia, which is classic, and then we resumed it thereafter without further neutropenia. Then in February 2018, he presented to the ER with hypertension and visual disturbance, and seen by his family doctor to control the to adjust his medications. In December 2018, he had a drop in his hemoglobin and his ferritin. He had a colonoscopy showing diverticulosis and G-scope showing gastritis. So he had some bleeding, in part related to the ibrutinib, and this was treated with iron replacement and antibiotics for the H. pylori. Again, in June 2020, he went to the ER with hypertension, and throughout these 2 years, there was ongoing issues with controlling blood pressure. Acalabrutinib became available to us in the summer, and so I decided with the patient that it would be a good idea to consider a switch to acalabrutinib, which he agreed to. And now we're seeing our CLL patients largely virtually, so I haven't seen the patient, but he reports a much better control of his blood pressure. It's around 140/70. He's not seeing his family doctor very often. And so this is a patient whose adverse events on ibrutinib were managed by a switch to acalabrutinib. He still has a low ferritin, but his hemoglobin is no longer dropping. This is a 76-year-old man with a history of low back pain. He's a smoker with no other significant history, who presented with CLL in 2016 when he had severe anemia due to autoimmune hemolytic anemia. We treated that in 2016 and in 2017 with steroids and rituximab. But in 2018, he had progressive lymphocytosis and anemia without autoimmune hemolytic anemia. And when at this time, I decided he needed treatment for the CLL itself. I assessed the cytogenetics and found he had a 17p deletion. So he was put on ibrutinib, 420 milligrams in November 2018. And while on ibrutinib, he reported severe leg cramping down both thighs, stiffness in his hands, stiffness in his knees, and low back. And we did all kinds of rheumatological, neurological assessments and found not very much, and concluded that it was related probably in part or large part to the ibrutinib. So in November 2019, I dropped the dose of ibrutinib to 280 milligrams, so 2/3 of the dose. And I just want to comment here on some of the things that have been said by other speakers. So there are studies now that show that ibrutinib dose can be reduced from 420 down to 280 and even 140 because BTK occupancy or BTK receptor content decreases with treatment of CLL. So the more ibrutinib you give a patient, the less CLL there is, and the less the BTK activity seems to be present. And if you look at over time, BTK occupancy can be reached with lower doses of ibrutinib at 140 milligrams. So we in Canada are trying to launch a study. We call it ibrutinib. We call it CLL 321, where you start with 3 tablets of ibrutinib or 420 milligrams, go down to 2, and then go down to 1. So I guess in your context of issues with affordability for ibrutinib, it might be something to consider that you can eventually with time drop the doses from 420 down to 140 milligrams based on some publications, largely out of MD Anderson. Anyway, so we dropped the dose to 280 milligrams. There were no improvements in his symptoms. And so again, in July, when the acalabrutinib was available, I suggested that he try it. And he says now that he has less pain in his legs. He seems to only have pain in his knees. His hands are much better. And he is feeling a bit better on this drug. So again, issue of tolerability. And this is the last patient, an unusual case of a 53-year-old man with an untreated anxiety disorder who presented with fatigue and found to have CLL raised stage 4 with splenomegaly, anemia, thrombocytopenia, night sweats, and some weight loss. For him, I did a full profile from the outset because he needed therapy. And because he was young, I also tested for the IGHV mutational status. So his IGHV is mutated, no 17p deletion, no 11q deletion, and no TP53 mutation. The patient needed therapy, but refused it over and over again, and finally convinced him that he needed it. We in Canada would have to give him fludarabine, rituximab, and cyclophosphamide, but the patient categorically refused to receive chemotherapy and was worried about the pre-medication with steroids because of his anxiety disorder. He was certain it was going to make it worse. Anyway, so managed to get ibrutinib for him with a special request to the provincial government. And he started that in November 2019. He developed diffuse petechial rash on his chest, on his back, but he responded very well with an improvement in splenomegaly and a resolution of B symptoms, and some improvement in thrombocytopenia. I had to hold the dose, the drug more than one time because of the rash, which was quite bothersome to him. And finally, we decided to drop the dose to 280 milligrams, which didn't provide an improvement. And then on his own, he and his wife decided that he would take 1 tablet alternating with 2 tablets of ibrutinib to manage the rash, which seemed to help. But, this is, although I did say that you could drop the dose of ibrutinib over time, this was quite early in his treatment course. And this is a young patient, relatively young patient with what I consider to be a relatively aggressive CLL based on its clinical manifestations, maybe not its molecular profile. And so I advised him to switch to acalabrutinib. And when he's finally switched, he no longer has rash and he is able to tolerate it. So, that was my last case. I hope I provided you a clinical context for the use of acalabrutinib, at least in our Quebec and Canadian context. I thank you for your time and attention. And if you have any questions, I'm open to answer.
Thank you, Dr. Sarith Asin. Thanks for the very good talk, and you brought about all the points in the importance of the second generation BTK inhibitors, particularly in the relapsed refractory chronic lymphatic leukemia, and definitely you showed that their beneficial effects and also how best they are tolerated better than that of the first generation BTK inhibitors. Thank you very much for the nice talk. And any questions we will take, I think, along with the panel discussion. It is over to you, Agarwal sir, please, sir.
Thank you, Shekhar, and thank you, Dr. Sarith. Request Dr. Sarith to remain with us for the panel discussion. I'll just share my screen. So we now have this panel discussion on chronic lymphocytic leukemia. I'll be moderating this. So we have the international expert with us for this panel discussion. And our panelists now are Dr. Satish Kumar from Bangalore. He's from Columbia Asia Referral Hospital. Dr. Ashish Dikshit. He's also from Bangalore, from Manipal Hospital. Dr. Chirag Shah. He's from Ahmedabad, from Apollo Hospital. Dr. Shishir Seth, he's from Delhi, from Apollo Hospital. And Dr. Soumya Mukherjee, he's from Calcutta, Apollo Hospital. And Dr. Jai Chandran, he's from Chennai, from Cancer Institute. So that's our faculty for this evening. And we will discuss some questions. First is to Dr. Satish Kumar. What are the diagnostic tests that you would like to perform in a case of suspected relapsed chronic lymphocytic leukemia? Satish.
Thank you, sir. Good evening, everyone. So in a patient with suspected relapsed CLL, we will do the basic test, which is a CBC with differential peripheral cell examination. We should first identify whether the patient has criteria for relapsed CLL and whether he fits into International Working Group CLL response criteria for progressive disease. So along with the CBC with the peripheral smear and differential, I would do a flow cytometry, even if on peripheral blood, to determine the immunophenotype of the circulating lymphocytes, and also identify whether the patient has any evidence of p53 inactivation. We can do a FISH for 17p deletion, because there is a risk of clonal evaluation in relapsed CLL. And we have seen that around 50%, in some studies, around 50% of the relapsed CLL patients can have TP53 mutation. I would also do a TP53 mutation screening by Sanger sequencing or NGS, preferably NGS. So this TP53 mutation analysis has to be done in all cases of relapsed refractory CLL. However, IgHV mutation need not be done because it remains unchanged at relapse. Once we have done once in the early, we need not do it. If it is not done, definitely it should be done. If the patient has any cytopenias, then I would do a bone marrow studies also, bone marrow aspiration biopsy. And also if the patient has any suggestion of transformation, like say patient has significant constitutive symptoms or asymmetric lymph node growth or extranodal presentation or a very high LDH, then I would do an imaging, preferably PET CT scan, and identify the lymph node which needs to be biopsied. Preferably, if the SQV is more than 10, I would prefer that lymph node for biopsy. So this is in short, I would like to do the test in case of relapsed CLL, sir.
Great, Dr. Satish. Can we have some comments from Dr. Sarith?
I fully agree with with what Dr. Satish has said, that we would also look again for 17p deletion, TP53 mutation, which can be acquired, but IGHV status would not change. And yes, we're always looking to ensure that there isn't a Richter's transformation based on the clinical symptoms that you've described and the elevation of LDH as well. So we use a PET scan to do that. I don't know if that's accessible to you. Yes? You would also use PET scan. Yeah.
Thank you. Thanks to both of you. We move to the next question. This is a question to Dr. Ashish. Which is the most important parameter that you are looking for while selecting a treatment for a relapsed CLL? Duration of remission, quality of life, PFS, OS, MRD, fixed duration therapy, any other or even combination of these? Ashish?
I mean, it's a tough one because basically we are looking at all these parameters when we are selecting an agent for the relapsed refractory CLL. If you ask me a single factor or a single parameter to select out of these, then the duration of remission most of the time will be able to guide us with therapy and will be able to tell us in terms of what particular is the nature of the disease. If the period of remission has not been very long for the previous therapy, then in any case it is looking like more aggressive disease. So it automatically clarifies which agent to use further, and also tells us, like, if it's a long duration response after chemoimmunotherapy, then it automatically tells me it is a mutated IGHV rather than unmutated one, even if it has not been done at the baseline. So in terms of that, if a single parameter I need to look at, yes, duration of remission, but the quality of life is something that is the one that is also deciding along with that. Most of these we will prefer as a decision maker in that parameter.
Dr. Sarith, your comments?
Well, thank you for offering me to speak each time. But yeah, it's a little bit different for us, I guess, because we don't, like I said, don't give any chemotherapy in the relapse setting anymore. And so the debates that are going on in Canada now are, well, do you give a BTK inhibitor at the time of relapse after chemotherapy, or do you give venetoclax and rituximab? One is time limited, one has a very generally good safety profile and long progression-free survival. So how do you select between the two? And we still don't have the answer. Some of us say if you have a 17p deletion, TP53 mutation, you should be on a BTK inhibitor because it's not finite therapy, and the patients who were on Ven are particularly those with P53 and 17p deletion had a worse PFS after the treatment was stopped. As you know, Ven-R is a 2-year self-limited treatment. So those are the discussions we have, a little bit different from here.
Thanks, Dr. Ashish and Dr. Sarith. We move to the third question to Dr. Chirag. What are the major challenges you face while considering treatment of a relapsed CLL, especially from the patient's perspective? Chirag?
So yes. So can you hear me?
Yes.
Hello?
Yes,
yeah.
We can hear.
So from patient perspective, the one big factor in India is cost, of course. But other than that, we have a lot of patients coming from out of town. So travel is a concern, and the number of visits, number of laboratory tests required. Then patients with comorbidities, they have different preferences. And what they have had before is what their experience was with the chemotherapy in the past. So many of them are now with choices available. They don't like to have a chemotherapy again. So those are the main patient issues.
Thanks, Chirag. Dr. Sarith, your remarks?
I don't have much else to say. We also consider, as we say, comorbidities. What are the other medications the patients are taking? What are the risks of bleeding when selecting the BTK inhibitors?
Thank you. Next one is to Dr. Shishir. What is your preferred patient profile for selecting the following? chemoimmunotherapy, BTK inhibitor, BCL2 inhibitor. So patient profile for each one of these. Shishir.
So in relapse refractory setting, the chemoimmunotherapy now means having a limited role, but means still means in our country where the finances are limited, chemoimmunotherapy could be an option, especially if patient they have a very good earlier response of these chemoimmunotherapy. So we can again try the agent for these patients, especially means if patient they had received earlier FCR, we can again try with means BR like regime if finances are limited. If finances they are not a concern, then definitely newer small molecule targeted therapy they are means better option, especially if means there is a 17p deletion, then there is no doubt of using these agents because these are the drug of choice. So BTK inhibitor means with the availability of generic ibrutinib, they are relatively more affordable option than BCL2 inhibitor. So the advantage of a newer study of a BCL2 inhibitor that definite therapy means after 12 months of therapy we can means stop the BCL2 inhibitor. So that is a major advantage when we are discussing with the patient, because most of the patient they are not willing for indefinite therapy.
Okay, thank you, Dr. Shishir. Dr. Sarit, your remarks?
I don't have anything to add. Thank you.
Okay. Dr. Soumya, next question to you. If you have been given an option of choosing either a BTK inhibitor or a BCL2 inhibitor for treating relapse CLL, what will be your choice and what is the rationale behind your choice?
Yeah, thank you, sir. So there are a lot of things which depends to choose the proper therapy for the patients. The most important, the first drug in the initial period, what drug he or she received before the relapse, that is very important. If the patient is on ibrutinib or any BTK inhibitor prior to the relapse, then definitely my choice would go for the venetoclax. But if the patient received VEN, then definitely BTK inhibitors will be the choice in the relapse refractory setting. And again, comorbidity, finance, both are important, very important to choose the drugs. So definitely, if you want to choose the second option, VEN will be my first preferable option if the patient received ibrutinib in the first, after the first diagnosis.
Thank you. Dr. Sarit?
No, I don't have anything more to add. I think a lot of this has been asked by other people here, but definitely the choice is based on the patient preference, patient lifestyle, what they previously received, and their comorbidities, and I guess affordability is a consideration as well.
Thank you. The next question is to Dr. Jayachandran. Is bone marrow transplant an option for treating a relapsed CLL? If yes, what is your preferred patient profile for selecting a patient for transplant?
Am I audible, sir? I'm Jayachandran. Am I audible?
Yes.
Yeah. So if you look at the CLL patients, usually they are more elderly patients and the HSCT index is always mostly higher side. So when there are few indications only nowadays to be selecting a patient for relapse refractory CLL, one would be in a younger patient where the 17p deletion, where they are exhausted both the options of ibrutinib and venetoclax, and still the patient is young and is having a matched sibling donor or a matched unrelated donor, where the comorbidities are less, we would consider for such a patient for allogenic stem cell transplantation. And in case of a chemosensitive Richter's transformation, in that case, we could consider such patient for allogenic stem cell transplantation. So we had offered for one patient. She was a doctor who is 37-year-old anesthetist who had a 17p deletion. Even she exhausted ibrutinib, venetoclax was not available. So only patient we had done for allogenic stem cell transplantation. I feel these are two indications in a younger patient with 17p deletion or more complex karyotype with less HSCT index and a patient with Richter's transformation be the indications for allogenic stem cell transplantation in CLL.
Thank you. Dr. Sarit, your remarks?
Yeah, I totally agree. It's a very rare patient, very rare patient in whom we do a transplant, but those would be good reasons too.
What is the response in Richter syndrome about the transplant? That was one of the condition, what was indication mentioned. So what's the sort of response and outcome?
Actually, we have not done offer any transplant for any Richter's transformation as of now, but as per literature, the responses are not that great. Even the responses are less than 30% with aggressive therapies, and after them being chemosensitive, taking them for allogenic stem cell transplantation would be a great deal. I don't know. Maybe Dr. Sai could have a great answer for this.
No, we have the same success rates. Very, very low, not successful. Very difficult. Yeah.
Dr. Sarit, they go for CAR-T?
Yeah, we don't have CAR-T available for patients in Canada for CLL at all, not even on clinical trials. Like I said earlier, we're looking at new therapies for Richter's transformation. We have some trials of bispecific antibodies and other novel things, but nothing established. Yeah. Difficult.
So that finishes one round of the question, and now we go to the last round of questions. We've got 6 more questions. So Dr. Satish, back to you. In a young, fit, relapsed CLL, what is your preferred treatment option and why?
So in a young, fit, relapsed and refractory CLL, depends upon whether he falls into high-risk category or not. High-risk category, when I say as defined by the recent EBMT European research in CLL group. So if he does not have any adverse genetics, and we have started him on a pathway inhibitor, whether it's BTK inhibitor or BCR inhibitor, and if he's responding well to the treatment, I would continue the same thing. I would not change anything. I'll just continue the pathway inhibitor. But if he falls into the high-risk category, which basically are defined into two, one is if he has a TP53 abnormality, he has failed chemoimmunotherapy, and is responding now to a pathway inhibitor. If he has a good match, like a well-matched donor without any comorbidities, I would prefer to take him for allogenic transplant. And if he has comorbids, or if he is has a bad performance status, or not a matched donor and is responding to the pathway inhibitor, I would continue that. If not, I would take him for transplant. The high risk category 2, where he has failed one pathway inhibitor, whether if he has failed ibrutinib or venetoclax, because of very high risk of progression or transformation, I would take him for allogenic transplant. Because the risk of transformation is very high, Richter's transformation is very high if they have failed one pathway inhibitor.
Again, Dr. Sarit, your remarks?
No, I agree. There's not much more to say. A young patient with relapsed refractory CLL, has a potential for a long life ahead of them, and so you do want to select the best therapy to give the longest progression-free and overall survival. And it is a challenge. I mean, our drugs are so effective, but they have their limitations. Transplant has to be considered. Not popular.
I have one question for you that was raised in between. If a person has toxicity to ibrutinib, cardiac or bleeding, will you ever switch that person to acalabrutinib or go on to venetoclax?
Yeah, that's a very good question. It's a good question. So the 208 study gives some information with regard to that there is not not overlap between toxicities between ibrutinib and acalabrutinib. I mean, there is some, but you can have a lower rate of these toxicities if you switch from ibrutinib to acalabrutinib. And then it is it's a shame to lose the BTK drug based on adverse event only, because the only other option left is the venetoclax, either alone or in combination. So if possible, it depends on the clinical context itself, but if possible, it's best to switch to another BTK inhibitor. In our case, it's acalabrutinib, rather than switching class of drug. Yeah.
Thank you. So, Ashish, according to you, which of the following is the ideal sequencing strategy for treating a relapsed CLL? So I need not read out all this. This has been mentioned and it was sent to you.
Right. So I think chemoimmunotherapy is going to be the last option as a palliative care, if at all I have to use it, provided the person can afford the other two pathway inhibitors. So in terms of that, again, it will come down to if the patient is younger, then if it is still a good risk, I'll prefer to use a therapy which is going to offer a treatment-free interval. So there I may choose a venetoclax-based therapy for a longer interval, or maybe 2 years of therapy and followed by withdrawal as an option. BTK inhibitor will be at the same time an option if they don't mind taking it for a long time and with a reasonable toxicity, which will be which will be also almost equivalent in terms of as long as it is sensitive. Quite a lot of the sequencing also will depend on which particular regimen was used before they became resistant. So if it has already been resistant to BTK inhibitor, then of course the sequence will change to the other type where the BTK inhibitor will not figure at all. So I think the combinations will exactly depends on what was used earlier, what it is resistant to, and it will come down to the fitness of the patient, the wishes of the patient in terms of being on the medications all the time, and what are the comorbidities at the end of the day, whether if there are cardiorespiratory, cardiovascular toxicities already existing, then in that case, possibly BTK inhibitor will be tough to administer. But if there's a renal toxicity, then BTK inhibitor will automatically become the first choice.
Thank you, Ashish. Dr. Sarit?
Yeah, no, I agree. You have to consider the comorbidities and the patient preference. The only thing the additional thing I'd like to say is if there is a 17p or TP53 mutation, most of us or a lot of us are uncomfortable with the venetoclax time-limited option, and so it would either be a venetoclax long-term if you can get it, which we can't, or a BTK inhibitor in those patients.
I have one question for you. Is MRD licensed to be used in clinics in Canada?
No, we don't have access to MRD, not yet at least. And for the time being, there are no therapies that are tailored based on MRD status. It's mostly for prognosis, so we haven't felt the need to use it in the clinical setting. In the research setting, it's very useful because it kind of gives you a really good sense of the depth of quality of response to a therapy. And for time-limited therapies, I think for BTK inhibitors, the MRD is not there, but the PFS is clearly can clearly be shown for all of them. So MRD might not be a pertinent measure or isn't for BTK inhibitors alone, but in the combination with BCL2 inhibitors or in the context of time-limited therapy, it's going to become more and more useful, or treatment tailoring.
Thank you. Another question I have for you is, do you always stop venetoclax after 2 years in relapsed and 1 year in an upfront setting, or if there is inadequate response, you continue?
The drug is only, the venetoclax in front line and second line are only licensed for time-limited therapy. So 2 years in relapse and 1 year. We cannot give it beyond that for reasons of cost. Yeah. Right.
Okay, thank you.
But the data, for Murano show that those people who relapse do it or lose their MRD do it fairly early after or during therapy even. So that, anyway, yeah, no, not available.
Right, got it. Question to Dr. Chirag. How do you compare the use of ACAL in relapsed CLL as in the ASCENT study, against Ibru in RESONATE study and venetoclax in Murano study. Please tell us the key highlights of ACAL over Ibru and Veneto in treatment of relapsed CLL.
Thank you. When I reviewed these three studies sort of to try and compare, of course, this is all cross study comparison, but it was quite interesting that between the Acala and ibrutinib, some of the differences are related to the side effects as highlighted, the lower incidence of hypertension, somewhat bleeding, and a little bit of difference in atrial fibrillation. At least in these studies, the AFib difference was not very big between RESONATE and ASCENT. Then the discontinuation rate has been considered bigger for ibrutinib due to side effects. Now comparing the Murano study, the venetoclax plus rituximab, the main advantage has been the fixed duration therapy. Other than that, when I first read about the trial, I was concerned that the TLS would be a very big thing. But in the Murano study, the TLS rate is 3%. So that's not very big. And it means that it seems that if you follow the exact guidelines given how to prevent TLS, the low risk, medium risk, and high risk patient, then I think it seems like a doable thing, at least on this clinical trial data. I don't know. All in all, it's, now we have to wait for the direct comparison of Acala versus ibrutinib. But as of now, we can say that we basically have three good choices rather than one clearly superior over other. Acala is, as per the data so far, seems more tolerable, and the best studies that I found was where the ibrutinib intolerance, Acala was used and tolerated well by most of the patients. So I think that was a better comparison for me of ibrutinib versus Acala.
Dr. Sally?
No, I agree with the assessment by Dr. Shiraga. The data that we have so far seem to suggest that in some cases acalabrutinib is more tolerable. And yes, we use Murano, the Venor, somewhat often, and do not see any TLS. It's a little bit cumbersome, with the dose escalation. There's a lot of blood tests, a lot of back and forth with the patient, but it is safe. Seems to be safe, yeah. So I agree. And I look forward to the acalabrutinib comparative trial. I think it will give us the best sense of how the drugs differ or are similar.
Dr. Sanet, any idea whether the coming ASH has this data presentation, ACAL versus Ibru?
Oh, I should have checked that out. I don't think so. I don't think it's coming at ASH, but I'd have to defer to AZ to know.
All right. Okay. So, happy to inform you all there are about 210 participants who are listening to us. Now to Dr. Shishir Seth. In your views in real world, will ACAL differ or will be preferred over other novel agents for the treatment of CLL? Shishir?
Data looks promising that acalabrutinib, that is a selective inhibitor, so the toxicity is limited, so better tolerable. So maybe it will be one of the preferred agent, especially when we are selecting this class, means ibrutinib versus acalabrutinib. And but how much difference it is with the other agent like venetoclax, very difficult to say, because the study that is with venetoclax, that definite therapy, that is after 12 months it can be stopped. So I think we need more data to mature to say whether means acalabrutinib that is also can be used as a definite therapy, who are means achieving MRD. After MRD we can stop the drug and see.
Thank you, Shishi. Dr. Sarit.
Sorry about that. I think we'll have to see what happens. In Canada, acalabrutinib is fairly newly accessible, and so with a little bit more time, we'll see if it's going to be used more. I don't know. Some of the U.S. experts seem to favor the acalabrutinib for its safety profile, but time will tell.
So now the second last question is to Dr. Soumya. In the treatment of CLL, do you think that BTK inhibitors can be used as finite fixed duration therapy, BTK inhibitor based treatment for a fixed?
Yeah, I think till date the data which we are getting that any BTK inhibitors should be continued for longer durations. No finite therapies there. A few studies definitely on acalabrutinib is there that they're going to stop the drug after a few years. But the issue is that MRD, I think, will be the most important determinant in those trials. But for now on, I think it is not advisable to stop the drug after a finite duration till the data matures.
Thank you. Dr. Sarit.
Yeah, I agree. There are some data coming out of Resonate 2. So in the frontline setting, patients who needed to stop BTK inhibitor for intolerance, not for loss of response. And they were able to maintain their responses off of the therapy, particularly if they were in CR versus PR. But that's not a common occurrence. And I would say that BTK inhibitors must be given indefinitely, until relapse or intolerance. But it may be fixed when given in combination with BTK with a BCL2 inhibitor. And I agree, MRD will help to define that.
Thanks. We come to the last question to Dr. Jayachandran. What is your opinion on fixed duration therapy while using BTK inhibitor-based combinations? And lots of combinations have been put over here. I don't know how much of that data is available to us, but anyway, your comments.
So all the combinations, all the permutations and combinations of this combination of ibrutinib or BTK with BCL2 and also an CD20 antibody. These all combinations have been tried in phase 2 clinical trials, and most of them had endpoints of MRD-based endpoints, response-based endpoints. And if you look at, I think MRD has not come into the clinic set, and how far achievement of MRD would translate into survival benefit is a great question. So again, there are pros and cons of using the combinations. In India, again, the cost is an issue, and I would love to sequence rather than give all at a single time. Even though they are at finite treatments, most of them about 15 cycles or within 2 years, something. Most of the trials have shown all are based on MRD endpoints. I would love to sequence them one by one rather than using at one go. Maybe for a younger patient who is affordable, maybe we can give it for a finite treatment. And it is better to see whether we can use the BTK inhibitors as a finite treatment as per the previous question. Maybe we should think about sequencing rather than using at a single go.
Okay, one last time, Dr. Sarit's remarks.
Yeah, no, I totally agree. I think combination BTK and BCL2 is not going to be very popular in Canada. The costs are just astronomical. So I don't really know what the future holds in terms of that. It's nice to be able to stop treatment, but we'll have to see. Seems costly. Yeah.
Right. So that was our last question, and
I have one question.
Please go ahead.
The cost of the drug of the novel agent, that is a big issue, and big affordability means we are using venetoclax in AML very frequently nowadays, and we have seen if we are giving along with voriconazole or posaconazole, the dose requirement of venetoclax that come down to 100 or 150 milligram per day. So means maybe for cutting down the cost of these drugs, we can use such agent. So the drug requirement will be much lesser.
Right, thank you. Yes, that has been done in AML quite frequently across the world. Okay, so I don't think there are questions in the question box. Kalpesh, there are any questions lying? I don't see.
There are 2 questions, sir.
There are 2 questions. Will you like to put them up?
They are already there, sir.
They are already covered. All right, thank you then. So, on my behalf, I thank everybody, Dr. Sarit and all the Indian faculty for sparing your 2 hours and educating all of us and those 200 audience, of which almost 100 are our fellows and trainees, and I'm sure that they have benefited from the experience of all of you, and grateful to Dr. Sarit for her expert remarks. I've been informed by AstraZeneca, Dr. Drupad, that ACAL versus IBRU data will be presented in ASCO 2021. So fair enough, in 6 months we will have that. And over to now AstraZeneca for the vote of thanks.
Thank you so much, Dr. Agarwal. I think it was a great session, and I would like to convey my sincere thanks to Mumbai Hematology Group for organizing this wonderful webinar, to Mice Ideas for the logistic support in executing this webinar very well, all the panelists and our speakers for the session today. Special thanks to Dr. Asulin for giving that wonderful talk on acalabrutinib in relapsed refractory setting. And I would also like to thank our entire audience. We've received wonderful participation from the audience, so they have made the event absolutely successful. Once again, thank you very much. Thank you, Dr. Agarwal, for this session, and good night, everyone. Stay safe.